Thanks so much, Isaac. And thank you for joining, everyone. We're going to be recording the session so that we can archive it in our materials so many other people can also benefit from Dr. Talbot's talk. I'd just like to briefly introduce my colleague, Dr. Keipp Talbot, who is an infectious disease expert at Vanderbilt University Medical Center. She is really a national and international expert in her own backyard. She's done some of the leading research on flu vaccination in the elderly. She's an expert in pneumococcal vaccination. She's an expert on COVID vaccination. And she sits on the CDC's National Advisory Committee for Immunization Practices that makes recommendations about how we should use the research as we deliver patient care. Dr. Talbot's going to share with us today her recommendations and synthesis of the evidence around vaccination for elderly individuals with regard to flu, pneumococcus, and COVID. And Dr. Talbot, thanks so much for joining us today. We're really looking forward to learning from you.
I am super excited to be here, and unfortunately, the camera is not working. So you'll be able to hear me, but not see me. Some ways that might be good. I'm going to try to share my screen, and I've actually asked Isaac to help if it doesn't work. Isaac, can you see it?
Yep, we can see your screen perfectly.
Okay, fantastic. Let's see if I can even figure out how to make it like the real view. All right. Still good?
Yeah, I think that you're going to want to, you see on the top of the screen where it says display settings, you're going to want to click that and then swap. That's what you want.
Okay, perfect. All right. So Dr. Kripalani warned you, and so did Isaac, that there's lots of questions. And so I really tried to make this very simple slide so that we had lots of times for question. And I also would love to be interrupted. Isaac, you can help me if hands go up, just so that I can explain things as I'm going. Adult vaccinations are incredibly difficult and complicated because they're done by pediatricians. So I struggle a little bit every year. I sit on the advisory committee for immunization practices. I'm one of the few internists, and I'm the only internist that really kind of specializes in aging adults. And so I do a lot of discussing, or which is a nice term for arguing about how we should make things simpler and more coherent for the older adult population. So some of these recommendations I will talk about today are no means simple, but we are continuing to work on them, and hopefully we'll continue to advance them and make them easier. And there are some that are complicated that I will try to explain and try to make it easier, or giving you options to make it easier. Okay, so for that being said, all right, the first thing I want to talk about is the do you wanna. There's an interesting phenomenon in the vaccine world where we ask patients if they want their flu shot. We ask them if they want. I'm not saying you should give it to them without their permission, but what I am saying is there's very few recommendations that we give patients and we say, do you wanna? If a patient's having a heart attack, we don't go in and ask if we want them to, if they want us to unblock the blockage. We say, we recommend you go to the cath lab. When it is time to have colonoscopy screening, we never ask if they want a colonoscopy, because the reasonable answer for do you want a colonoscopy is absolutely not, I don't want that. I mean, who would want that? And so we always tell them it's time for your colonoscopy. I'm going to schedule you for your colonoscopy. The same for mammogram. But for some reason, we have relegated vaccines to the do you wanna. And we have actually, in an attempt to increase uptake of vaccination, it has become the person who checks in the patient or someone else to say, do you want a flu vaccine? And I think we really need to stop doing that. I think we need to recommend vaccines like we recommend any other preventive measure and any other treatment measure. It should be something like, it is time for your flu shot. You're at risk because of either heart disease or lung disease or age. And we recommend that you get it today. I can have so-and-so come by the room and give it to you before you leave. It's a very different concept than what we've traditionally done with vaccines, but I think it's an important distinction. It's amazing to me how many patients have said no to the do you wanna, and I walk into the room and say, it's time for your flu shot. And they look at me like, really? No one's recommended that before. Well, we've just been using the wrong terminology. So that's just something to think about as we progress through this, as we want to change the way that we vaccinate this population, is that we really need to change the way that we approach the patient when we talk about them. Okay, so I'm going to try to briefly cover flu vaccination, an update on the COVID bivalent vaccinations, and I'm very happy to take any other questions on COVID. And I included pneumococcus, which is probably a topic that we could talk about for hours, but I will try to simplify it and talk about the most recent recommendations that have since passed. All right, we talk about flu vaccination, and Dr. Kripalani was super nice and sent me the number of residents that y'all have vaccinated in the area for influenza. But I'm going to also talk about not just the residents, but the providers, and I'm going to show you why, and we'll talk a little bit about that. All right, so flu vaccine has finally changed the guidelines, or the guidelines for flu vaccines have finally changed. So we've had several vaccines on the market that have been licensed for adults over 65 years of age that we believe produce better immune responses and hence are more likely to protect older adults. One of them is the high dose vaccine. So let me just back up a bit. We used to call vaccines the TIV, the trivalent influenza vaccine, and now they all have all kinds of different fancy names with different letters. So IIV stands for inactivated influenza vaccine. If it has a high dose on the end of it, it means it's a high dose. If there's an A in front of it, it means it's been adjuvanted. And if there's an R in front of it, it means it's recombinant and not made in eggs. These are the three vaccines that we believe have enhanced immune responses in older adults. So the high dose vaccine has been around for a while. It's also known as Fluzone High Dose. It is 4 times the normal amount of hemagglutinin. The adjuvanted influenza vaccine is known as Fluad, and it actually contains an adjuvant called MF59. And an adjuvant is just a component of the vaccine that increases the immune response. It tells the immune system to pay special attention to this. This vaccine has actually been around for almost 30 years now in Europe, and it wasn't licensed in the US until a few years ago. The last one is the recombinant influenza inactivated vaccine, also known as Flublok. This one is often known because it's not made in eggs, which is very exciting. And because it's so easy to make, or so they say, they're able to increase the amount of hemagglutinin that's in there. So it's 3 times the amount of hemagglutinin. So a little bit less than high dose, but still definitely more than the traditional inactivated influenza vaccine. ACIP met in February and discussed these 3 vaccines and said any of these vaccines would be recommended for use in those over 65. In fact, they would preferentially be used over the other influenza vaccines that are not enhanced. Any of these 3 vaccines could be used. There's not one preference of one of these 3 over the others. So we talk about most people go get their flu shot. They usually get a standard dose inactivated vaccine, whether it was grown in eggs or not, doesn't matter. But for those over 65 years of age, we're looking at either giving a high dose, an adjuvanted, or recombinant vaccine. And this is recommended to provide better protection and prevent hospitalizations in those that are older. As I mentioned, most of us are really good at vaccinating our long-term care patients, but when it comes to vaccinating our hospital and healthcare employees, we're not quite as good. In the healthcare setting, in the hospital setting, we have really increased the number of healthcare workers who are vaccinated, which unfortunately was pretty much done by mandate by most hospitals. But some of the hospitals were able to do it by education alone. But if you notice in our long-term care settings, it's a lot lower. And the question I always get is, well, who cares? Because it really matters if the patients are vaccinated or not. And so I'm going to show you some data that helps explain why it's so important that we change this yellow bar to be up near the blue bar. This is a complicated slide, so don't start reading it. Just listen to me for a minute. This is a summary of 4 different studies that were done. These are studies that looked at vaccinating the healthcare personnel or not vaccinating the healthcare personnel at long-term care facilities. The x-axis is the 4 studies. The y-axis is the patient mortality. So very important to note that we are looking at the number of facilities that vaccinated healthcare workers and looking at patient mortality. Okay, so now we can look at all the details. So the first study was done by Potter et al., and they had 6 long-term care facilities in each arm. So the dark blue are the facilities that recommended healthcare vaccination and actually provided healthcare vaccination, compared to the light blue, which were the sites that did not actively vaccinate their healthcare workers. And what you see is almost half the number of patients died in the healthcare facilities that did vaccination. And this is vaccination of the healthcare workers, not necessarily the patients. The Potter study came under fire because it was too small, they said. And so another study was done by Carmen et al. And had 10 long-term care facilities in each arm. And once again, you notice that there's a reduction in mortality of the patients when the healthcare workers are vaccinated. This came under fire because it wasn't big enough. And so there was another study with 22 long-term care facilities in each arm. They didn't show quite the same massive reduction, but there still is a reduction in patient mortality in long-term care facilities where healthcare workers are actively vaccinated compared to not. The Lemaitre study was also done, unfortunately was done in a season with not a lot of flu and was not able to show a statistically significant difference. But you'll notice all other 3 studies were able to show this difference. And the healthcare vaccination rates weren't necessarily 100%. It was just the point of actively vaccinating healthcare workers prevented death in patients. And there are probably several reasons for this. One is we know our patients in long-term care facilities aren't going to gallivanting around town and church and grocery stores and getting flu and bringing it back. And yes, we have visitors that visit, but for the most part, most of the interactions that the patients have are with other healthcare workers. And healthcare workers do go to the grocery store and take care of children and go to church and go out to other places. And we often will come to work because we can't take the time off. And we feel like as healthcare workers, we're supposed to take care of people, often present ill. And so if we are vaccinated, we reduce the likelihood of bringing influenza into the long-term care facility and reduce the likelihood of spreading it. Now, is this 100%? Heck no. We've all gotten flu shots before and gotten flu. But we are less likely to spread flu if we have been given a flu shot. And this is incredibly important. We talk about in healthcare that we do multiple things to reduce the risk. Nothing we do is 100%. It's the same thing for driving. We wear our seatbelts, we have airbags. Now, none of that is 100%, but is more likely, we are more likely to survive a car crash and to survive well if we're wearing our seatbelt and have airbags. So this is a similar thought for our long-term care patients. We vaccinate them, but most importantly, we find that vaccinating the healthcare workers prevents mortality. Okay, I'm going to switch gears to talk about COVID. I really want to emphasize that we are building the airplane as we're flying this airplane. We are now almost 3 years into this, and we are still trying to build this airplane as we're still trying to fly it. I also want to talk very honestly about we are learning as fast as we can. The virus is changing as fast as we can. We'll come back to that topic. And so what we say one day may not be true the next day. And that is because we are learning and the virus is changing. So the information that I give you today is good for today and may change. That's why it's incredibly important we continue to message We continue to ask questions, and we continue to keep up with this data, which is very hard to do. I'm having a hard time doing it, and that's my full-time job. I'm really looking forward to going back to just working on flu. At some point, we're going back there. So what I tell you now may not jive with what you were told 2 years ago, and that's okay because we've learned a lot. And I also tell you that because your patients are going to be like, hey, but that doesn't make sense. We were told this, and that's okay too. The more that I can tell you, the more questions that you can answer your patients. All right, this is a graph that shows how quickly that this virus has changed. As each color is introduced, it overwhelms the board and becomes the predominant strain that's circulating. And if you notice, before one has even had a chance to become dominant, there's another one coming right behind it to take over. This is currently where we're at now, where BA5 is the predominant, but you notice there's some BA4 that's coming in and sticking around, and then some other ones. I'm going to go back to this just to show you. Each time that we've talked about making a variant vaccine, so what do I mean by that? The vaccines that we have used until recently have all been based on the primary vaccine strain, which is the primary Wuhan strain. Companies have realized that these variants are coming and have said, okay, I'll make a variant strain. And each time that they've made a new vaccine, the variant has changed again. So the circulating variant has changed on us. And none of those previous variant vaccines have come to market. In fact, most drug companies or pharmaceutical companies who made a messenger RNA vaccine have actually made a BA1 variant. So that's that dark purple here. And actually tested it in humans. But as you can see, what we're looking at now is BA5. So what the FDA decided to do is they were going to take the data that was done on the BA1. So what does this mean? Both Moderna and Pfizer, who make the messenger RNA vaccines, had developed a BA1 variant vaccine, but they also decided to use the ancestral. So they have both the original and the BA1 in them. And the reason why they decided to do this is as the variant changes, we don't know which direction. Will it go back towards the ancestral strain or more to one of these Omicron BA variants? And the idea is if we put both strains in there, we are more likely to be covered for whichever way that the virus is going to change. We do this somewhat similarly with influenza. Every year, I hate to use the word guess, but we really do guess every year which flu virus is going to circulate in the next year. And we put in multiple different viruses because we don't know which strain or which type of virus will circulate. So very similar to flu vaccine. In other words, we're covering all of our bases and we're trying to figure out what's going to circulate. So Moderna and Pfizer both created these vaccines with the ancestral strain and a BA1, and both of these vaccines were tested in humans and were tolerated as well as the previous ones were. When they took this data to the FDA said, that's nice, but BA1's not circulating. We want BA5 vaccines. And so that's exactly what the companies did. They created a bivalent vaccine with both the ancestral strain and then the updated BA4, BA5.
Hey, Dr. Talbot, why is there such a discrepancy in the amount of like vaccine between the two vaccines? So 50 versus 30.
Yeah, great question. Let me finish this and we'll come right back to it because that's a fantastic question. So both companies brought these vaccines to market and just swapped out the BA1 for the BA4 or BA5. This is very similar to what we do for flu vaccine every year. We swap out the strain that we think will be circulating. So this is what has come to license and this is what is recommended. And everyone should receive the bivalent vaccine as long as they've, it's been at least 3 months since they had COVID and at least 2 months since they've had their last COVID-19 vaccine. I would think of this vaccine, the bivalent vaccine, like our annual flu shot. This is the updated, this is the most up to date, and this is what should be given to everyone. That is as long as they've received their original doses. Okay, so this is a great question. I'm actually going to go back to the slide so you can see. Moderna and Pfizer were actually in a race to who was going to come to market first with their vaccine. They were the same concept. They were both messenger RNA vaccines. They both used the spike protein as the target, and they both had a stabilized spike protein. Since they were working independent of each other, there were some slight differences though. Moderna put a higher dose in theirs. Moderna had a more heat stable envelope that went around the messenger RNA. How much these differences between the 50 and the 30 microgram makes is totally unclear, because we've never tested these vaccines head to head. But that's how these came to license. Interestingly, Moderna decided to give their vaccine on day 0 and 4 weeks later. They were actually ahead of the curve and were going to be licensed first. Pfizer BioNTech was right behind them and didn't want to finish second, so they changed their vaccine to be given at 0 and 3 weeks. So that's why they were able to finish first, is because they actually just gave their 2 vaccines closer together. There's no scientific reason for that. And actually, as we looked over time, probably the best way to give these vaccines would be 0 and 2 months and 6 months, but that was not what happened because we were trying to get everyone vaccinated so quickly. In the US, we had to stay within the FDA EUA guidelines, which was the 3 week and 4 week, but other countries around the world actually spread them out a little bit more. So there are some mild differences, but overall we see similar efficacy and effectiveness in these two. And I think later we will actually do some more trials of head-to-head data, which will be really interesting. All right, so pneumococcus. So the Streptococcus pneumoniae is a very virulent pneumococcus. And there are many different types of Streptococcus pneumoniae. There are actually over 100. And we differentiate them by the sugars that are on the outside of the bacteria. This bacteria can cause pneumonia. It can cause meningitis. It can cause a blood infection, and it can also infect the heart, which we know as endocarditis. Is one of the most common causes, or used to be, of otitis media in kids, and sinusitis. We have called a vaccine for this bacteria the pneumonia shot for many, many years. The funny thing is it's not really great at preventing pneumonia, but was really good at preventing bacteremia and meningitis and endocarditis. That has changed over time, and we'll talk about that change. We have also started vaccinating kids for Streptococcus pneumoniae, which has done amazing things for adults. So it turns out that kids used to be colonized with pneumococcus, and they would visit their grandparents, especially during the holidays, and love on them. I like to say kids only willingly share body fluids. And so they would share their oral flora, and grandparents would be exposed to Streptococcus pneumoniae and then actually would develop pneumonia. We had these high spikes of pneumonia following the holiday seasons every year. It's pretty impressive. January 1st, huge spike every year. And actually, I always took off, I always worked Christmas and took off New Year's because that was when we had the high spikes of pneumonia when I was an intern. So the vaccines that most people are familiar with are the pneumococcal polysaccharide vaccine, and this is known as Pneumovax, and it's the PPSV 23. It has been around for many, many years. It was actually developed by Bob Austrian up in the Northeast, and we have given it to adults over 65, even when the rest of the world did not. The limitations of this vaccine is it did not create a very good immune response in those that are very young or very old. So the Pneumovax was primarily used in adults, used in some kids that had sickle cell disease. Because this was based on the polysaccharide, which is basically the sugar on the outside, it actually could prevent 23 different types of pneumococcus, but you can imagine it had variable protectiveness for those 23, and really for the most part prevented invasive pneumococcal disease, the bacteremia, the meningitis, the endocarditis, and diseases like that. Because pneumococcus remained a serious disease in kids, especially for meningitis in young kids, a vaccine was developed called the conjugate vaccine. And actually the first one was PCV7, which is not on here. But the idea of the conjugate vaccine, it was they would take those polysaccharides or the sugars that are on the outside of the pneumococcus and actually attach it to a protein, because proteins are much more likely to be recognized by the immune system, are much more likely to develop a broad immune response, and actually develop an immune response that is a memory response. And when they first developed PCV7 and 13, they actually first used it in kids and not adults. And kids had great responses to this. As I mentioned, they were no longer colonized with these actual pneumococcal strains, and it really reduced disease in older adults. It's pretty impressive. The decision was made until all kids got PCV13 to get PCV13 in adults, and then it was decided, oh, well, if you want it, you can get it. It was kind of a long, complicated vaccine recommendation that came and went. What we do know about PCV13 is that it did prevent pneumonia. So not just invasive disease, but in pneumonia, which is really important. Now, does that mean we've gotten rid of pneumonia in adults? No, because many different bacteria and viruses cause pneumonia, but pneumonia due to pneumococcus has reduced greatly. Our recommendation for PCV13 was to give PCV13 followed by the pneumococcal polysaccharide vaccine in adults over 65 years of age. Since that time, 2 pneumococcal vaccines have been licensed by the FDA and recommended by the CDC, the ACIP, and they include PCV15 and PCV20. So PCV15 has 2 additional pneumococcal strains in it, and PCV20 has 7 more strains than PCV13. So the new recommendation is that for those over 65 years of age, and those 19 through 64 with certain medical conditions, they can get either PCV15 or PCV20. If they get PCV15, they should also get the polysaccharide vaccine 23 to cover at least 20 different strains. So this is one of those times I'll tell you how to make this easier. If you just give PCV20 to everyone, you give them 1 shot and you're done. It makes it much easier than trying to give PCV15 and PCV23. All right. And so this is my quick summary on ways that we can improve vaccination rates. And then I would love to take questions, and we'll get rid of the slides and pull up everyone's face. All right. So the first important thing is the use of immunization information systems. The states all have registries of vaccinations. They're widely used for pediatrics. So if you change doctors, if you show up in the hospital, all of the immunization data is there. It can be printed and sent to the schools. It is so incredibly easy. We don't do this for adults, and it's even more complicated because adults get vaccines in multiple different settings and multiple different providers. My favorite is the story of we've done vaccine verification for years in adults, and someone got their vaccine at Kroger. Well, that's not as simple as you think, because then you have to ask, was it the Minute Clinic in Kroger or was it the pharmacy? Because those records are kept in different locations, some locally and some nationally. So we really need to start using our immunization information systems as vaccines for adults become more and more complicated and they change on a regular basis. As patients transition from one type of healthcare to another, we need to have access to what they were truly vaccinated for, by, and with. And we're only going to do that if we start using the immunization information system for adults. COVID has helped us incredibly in this because that was part of the mandate that if you gave a COVID vaccine, it goes into the immunization information systems, and it's made our life for COVID vaccines much better. But we really need to do this for all vaccines for older adults. 2, please don't use the do you wanna. Walk in, it's time for your flu shot, and if they say okay, then you give it. I think that's how we need to start really communicating this incredibly important prevention. It is not 100%, but nothing we do in medicine is 100%. We do everything to reduce the risk of disease. And when we reduce the risk of disease in this population, we extend longevity and we extend quality of life. And so we really need to start saying, it's time for your flu shot, your pneumonia shot, your shingles shot, whatever it may be, and don't use the do you wanna. 3, I think it's incredibly important we lead by example. What do I mean by that? I get my flu shot every year as a healthcare worker, and so when my patient asks me, "Did you get your flu shot?" I'll say, "Absolutely." I have gotten my shingle shot. I'm overdue for my number 2, but I have done it. So these are the important things that we need to talk about. We need to lead by example. We need to tell our patients that we believe this is an important preventive health measure and that we've done it. And it's really important for those of us who do any kind of management in healthcare to say, I got my flu shot, and everyone I work with should get their flu shot. Sorry. Okay, so this is just that one of those things of leading by example is incredibly important so that those that we work with and those that we treat can see that we do this. All right, and lastly is questions. So I'm gonna stop sharing and hopefully answer whatever questions that y'all might have. Especially, I know people have questions about COVID and pneumococcus. And y'all are being very quiet. You don't have to be quiet.
Dr. Talbot, thanks so much for your great presentation. I've been confused by the pneumococcal recommendations for so long and appreciate you simplifying.
It's the most difficult recommendation we have for adults. It drives me crazy.
Yeah, fortunately, we don't have to do them too often. I have 2 questions for you. One is just a simple one. The other one's probably more complicated. From the simple perspective, I think we're generally told that we can give the flu shot and the COVID vaccination together on the same date. Some nursing homes in our program might want to bundle even the pneumococcal vaccination in with one or the other of those if their patient is not up to date. Is it okay to give any combination of those 3 vaccinations on the same date to patients in a nursing home setting, or should they be spaced out a little bit?
Yeah, this is the catch-22. This is part of the building the plan that we talked about earlier. When we vaccinated, it is so much easier to do it all at one time while we have the patient in front of us. I think sometimes when we delay, we have missed opportunities and we never come back and actually finish the vaccination.
Mm-hmm.
On the flip side is that this is a time period where we don't know as much about co-administration of COVID vaccine with other vaccines. To date, we have not seen any alarming issues with co-administration. And we are following it very closely, and we have people report and we do systems reviews looking at co-administration. So it does appear safe. In some ways, there may be a benefit because the COVID vaccine is so reactogenic and so it stimulates the immune system so well, it actually might benefit giving other vaccines at the same time because they also might have a better immune response. But I do think we need to tell patients that it may be more reactogenic. They may be more sore. If they didn't tolerate the COVID vaccine very well for 24 hours, they're not going to tolerate it any better when we give multiple vaccines. So I think just being aware of that, but I think if you have an opportunity to vaccinate, we should take it.
Okay.
And I did get my flu and COVID shot at the same time. Yeah. Different arms, but same time.
Now for the more complicated question.
Okay.
And we may just not know the answer to this yet, but there are some saying that you can get the COVID booster once a year, like a flu shot. Mm-hmm. And other people saying that the antibody response lasts for 4 to 6 months. Yeah. And that may actually make some people hesitant to get a booster with the idea that it's not going to last all that long. But what do we know and what don't we know about how long the booster shot is likely to provide benefit?
Yeah. I think that's like about 5 questions in one. So let's see if we can unpack it and go from there. There are several reasons why we were giving vaccines as often as 4 to 6 months. I think the first reason is that 2 vaccines close together, like we did, provides really good immediate response, but does not provide long-term protection. Most vaccines that we give that are like the COVID vaccine, and I'm not just talking about messenger RNA, I'm talking about an inactivated vaccine, like our flu vaccine or our current shingles vaccine, any of those, if you give them and spread out the doses, we have found that we get better, prolonged, lasting immune responses. When we first started the pandemic, though, our goal was to get everyone 2 vaccines to stop the pandemic, thinking that that would put an end to the pandemic, and that was incorrect. The pandemic is here to stay. This virus is here to stay. We're never getting rid of it. And so looking back, this probably should have been a 3-dose vaccine, a bunch too close together to immediately control the hospital overflow issues and the large number of deaths, and then give one 6 months later to create that long-lasting immune response that we're going to need. So that was kind of the first realization we probably should have had, not what we thought of as a booster, but a 3-dose series. When that realization came about, the FDA had already called them boosters, so we wanted to change them to a 3-dose series so that everyone got 2 doses close together and 1 6 months apart, and that was not the definitions under the EUA, so we were not allowed to change the definitions of how to give them. This became even more complicated, though, because the virus changed rapidly, and so we were giving boosters to increase the antibody responses so that the antibody responses would not only be appropriate for the vaccine that we had made, for the virus we had made the vaccine for, but for all the variants. So if we could just get the antibody levels high enough, we could protect from the variants too. And so it wasn't just a matter of waning, it was that the virus was changing. And so that made it even more confusing. And then, yes, there is always waning of protection when it comes to respiratory viruses. So I think we were looking at 3 different issues all into one. One is that to really stimulate the immune system appropriately, you need to give vaccine doses at least 6 months apart. 2, the virus changed rapidly during that time. And 3, we probably needed variant vaccines. And so it became part of that time I talked about where information changed so much over time and everyone's confused and doesn't know what to believe anymore. That is part of that flying that plane. I do not think it's sustainable to vaccinate everyone every 6 months. And I think that was one of the reasons why the FDA finally said we need the variant vaccine. And so the hope is that we will give the variant vaccine. Everyone has had multiple doses, at least 6 months apart for some of those, to create the right immune response. And hopefully, COVID will return to being a seasonal virus like other respiratory viruses. But I cannot tell you any of that is true. All I can do is tell you what we know today. And what we know today is that giving a bivalent vaccine will provide better protection for our older adults and will likely reduce severe COVID disease. Hopefully 6 months from now, I can tell you more, but that's it for now. And it is incredibly frustrating for everyone in healthcare and in the public to not have the answers that we're all used to having and knowing what we're supposed to do. And then some groups saying we know exactly what we're doing, and then that changes, and that makes it even more confusing and frustrating, I think. So at this time, I can tell you the COVID boost bivalent shot, you can think of it as an annual flu shot with the right strains in it, and we will see how long that protection lasts, and then also what the COVID virus will be doing. So probably not the answer you wanted.
Yeah, that's fair though, and I appreciate the honesty. What other questions do attendees in our webinar have today.
Hi, I'm curious about the people under 65 with the pneumococcus.
Yes, keep going.
Well, I'm just wondering, are we giving them the Prevnar 20? And if so, after 65, would we administer another one?
Yeah, that's a great question. So yes, there are some adults under 65 who should be getting the Prevnar 20 or the PCV 20. And there's actually a very long list of people who qualify for that. There used to be 2 lists for those under 65, and I was actually able to get them to combine. That's as far as I got with simplifying it. So now anyone who's at risk for pneumococcal disease that's less than 65 should get PCV 20 or PCV 15 plus polysaccharide, but that's much more expensive to do. Those people included those with diabetes, smokers, asthma, any kind of immune suppressive like HIV, any of those that don't have a spleen, anyone who has a cochlear implant, because that is actually increases the risk of pneumococcal meningitis, a CSF leak, any of those with any kind of cancer, anyone getting any immune suppression, so 20 of prednisone a day or more, any of the other big immune suppressing things for transplant or for something like Crohn's or rheumatoid. So that's a large part of our population actually who is eligible for pneumococcal vaccine under 65. And so they should get either the PCV 20 or PCV 15 plus polysaccharide. And you know my bias because I think one and done is much easier. What do we do when they turn 65? We don't know yet. I think we're going to have to reevaluate redosing of the vaccine, but at this time, no one's made recommendations for redosing.
Okay, thank you.
You're welcome.
Hey, Dr. Talbot, I had a quick question. I kind of have heard generally that, mixing and matching between the various COVID-19 vaccinations was an okay thing to do, maybe even a good thing to do. Could you just talk about that for a little bbit? Like, if I had gotten the Janssen shot originally and then Pfizer, or, just kind of through that entire process, if some folks may, let's say I'm, in a nursing home and I haven't really heard as much about it. I'm, kind of adamant I got Pfizer the first time. I don't want to get anything other than Pfizer. How do you kind of approach this sort of conversation?
Yeah, that's a great question. And there actually has been a very small study done by the NIH looking at the mixing and matching. Originally, when everything was under EUA, we were not allowed to recommend mixing and matching. We were only allowed to do that when there was no other vaccine available. But now we have lots of vaccine available and it's a possibility. There has been some benefit with mixing and matching some of the vaccines together. However, the majority of the vaccines that we have been using are the messenger RNA vaccines, and there has been no proven benefit of mixing Pfizer and Moderna. It's just as good. It looks like it works just as well. It's the same mechanism. And so actually, the person who developed that vaccine used to be one of the Vanderbilt faculty. And when we were discussing the Moderna vaccine with Pfizer, he's like, they're interchangeable. I'm like, yes, but we're not allowed to say that. But really, essentially, they are interchangeable. And there's no benefit from giving one over the other. When it comes to ones like the Janssen vaccine, there probably would be benefit from mixing and matching with the messenger RNA, but we are not recommending that as a first-line vaccine, as patients have had, especially older adults have had Guillain-Barré with it. And we know with the messenger RNA vaccines, we did not see that. And then the Novavax is new. We don't have as much data to compare head-to-head because it was introduced later and the vaccine efficacy data was later. There may be some benefit from mixing and matching those, but I think we're still kind of waiting to hear that information. I think the most important thing though is just getting vaccinated at this point.
Great, thanks. And anyone else? We got about 10 minutes left on the call today. So if you have any other questions, please feel free to ask Dr. Talbot at this time.
And if there's something that you don't want to ask out loud, you can also email it to Isaac, and I'm happy to answer. I think it's easier to vaccinate if we know what we're doing and understand it and are comfortable with it too.
I guess I have one last question, Dr. Talbot. You've kind of already touched on it, but in terms of eligibility criteria for boosters, is it really just, you know, making sure their last shots were, was it 3 months prior, or like what exactly is, like, is it that simple? Just as long as their last vaccine was more than 90 days ago, they're eligible for the booster, or is there anything a little more nuanced than that?
No, it's not more nuanced. And I probably should put in, they should have had their primary shots. Their last COVID vaccine was at least 2 months ago, and they haven't had COVID infection within the last 3 months. But other than that, yes, everyone should. So think about this now as in everyone's gotten their flu shot and their COVID bivalent is how we should be thinking about it. I appreciate everyone's time today. I'm serious. If you have questions that you want to send to Isaac to forward to me, I think that's great. Please stay safe this virus season. We're seeing flu already in Tennessee, and RSV and COVID. So hang in there, and we appreciate all that you do.
Yeah, thanks so much, Dr. Talbot. I've recorded this session, and I'll be disseminating it out to all of the nursing homes that are in our listserv, all of our contacts. So I will be sure to keep an eye on my inbox to see if anybody has any additional questions they send my way, and I'll be sure to get them to you.
Thanks.
But other than that, yeah, I think we'll go ahead and just end this webinar now. I want to thank everyone for attending, and we'll be back next month with a topic of long COVID. So you'll see that invite for that webinar come out probably early next week. But thanks for your participation today, and looking forward to next month, and we'll talk soon. Take care.